Nisha, just leave from this thing. Leave the screen. Okay. So, shall we start, Ankit?
Yes, sir. It's
Yeah.
meeting
Okay.
is live now.
Yeah. Okay. Good evening and welcome to the PG classroom. This is actually the first program of the present team of scientific committee, and we have Dr. Thomas Serian, President of KSOS, and Dr. Biju John, Secretary of KSOS, along with Dr. Marian Poli, who will be coordinating the PG classroom. So the scientific committee has started a lot of programs for the benefit of postgraduates. And this month, on 25th of Sunday, again, we have a physical PG update program at Little Flower Hospital, Angamali. And today, Dr. Nisha from Giridhar Eye Institute will be presenting a case. And we have none other than Dr. Bhaskar Srinivasan from Shanganathalaya, Chennai, along with Dr. Sugaranjini from Giridhar Eye Institute, Kochi, to lead the discussions. So this program will be live on the YouTube. And those who are watching the program in the YouTube can type your questions in the chat box, and we'll have the discussions about these questions towards the end of this program. Before we go to the case presentation, I request our president, Dr. Thomas Serian, to say a few words and formally inaugurate this program. Over to you, sir.
Thank you, Bastian. Dr. Bhaskar, Dr. Sugaranjini, and dear friends, education is the single most important activity of the Kerala Society of Ophthalmic Surgeons. And this PG classroom is the right step in training and motivating the postgraduates, preparing them for their examination. And the KSOS is taking a good step for this. The scientific committee, led by Dr. Bastian, ably assisted by his team of scientific committee members, are organizing a year-long program in the form of PG classroom and other academic activities. And I congratulate the scientific committee for this activity. This being the first program, I congratulate and I invite all of you for this. I am sure this program will benefit our postgraduates more than anyone else. But at the same time, all our ophthalmologists are welcome to attend this program, and this will enrich your knowledge to a large extent. With these few words, I declare this PG classroom inaugurated, and let's hope that we'll have a fruitful year of education. Thank you.
Thank you, sir. Over to Dr. Nisha. You can share your screen and start the presentation.
Yes, sir. Good evening, everyone. I am presenting a case of 22-year-old boy from Ernakulam, presented with the complaints of defective vision of both eyes since 5 years, and itching and rubbing of eyes was present in both eye, left eye more than right eye. History of present illness: the patient complains of gradual onset of defective vision in both eye, which was painless and progressive since past 5 years. He consulted elsewhere and was diagnosed to have some corneal disease and was referred here for further management. The patient underwent corneal transplantation surgery for the same in the right eye 5 years back and is on follow-up since then. And the patient complains of itching and constant eye rubbing in both the eyes since childhood. And there is a history of frequent change of glasses, and there is no complaints of pain, redness, photophobia, glare, or monocular diplopia. There is no history of floaters or flashes. There is no history of trauma or injury to eye. And on past history, this history of spectacle use is present since 5 years, and history of contact lens use was present 5 years back. And he underwent corneal transplantation surgery in the right eye 5 years back and was on follow-up since then. And there is no history of any nasal allergy or any systemic illness in the past. Family history: there is no history of similar illness in the family. There is no history of any significant ocular illness in the family. Personal history: the sleep and appetite is normal. The bowel and bladder habits are normal. There are no addictions. And on general examination, the patient is conscious and cooperative and well-oriented in time, place, and person. Is moderately built and nourished. The pulse rate is 70 per minute, regular in rhythm, normal in character. And the blood pressure is 110/70 millimeter mercury in the right arm in the sitting posture. And the systemic examination was within normal limits. And coming to the ocular examination, the head posture was normal. Ocular position was orthotropic. There is no signs of orbital fat atrophy. And assessment of vision. The visual acuity in the right eye is 624, improving to 66 with -4 D cylinder at 50 degree. And in left eye, it is 2-meter counting finger, improving to 624 and 18 with -4 D cylinder at 80 degree. And coming to the anterior segment examination of the right eye, the lid and lacrimal apparatus is normal, the rhoplast is negative, conjunctiva is normal, sclera normal, and cornea is normal in size. And there is a centrally placed graft, and the graft house interface appears clear except the supratemporal quadrant. There is a corneal opacity from 9 o'clock to 12 o'clock position, and you can see 10-0 nylon interrupted sutures are present in graft house junction, and the sutures appears intact. And the anterior chamber is normal in depth and it is optically quiet. And iris is normal color and pattern, and surgical peripheral iridectomy is seen at 1 o'clock position and it appears patent. The pupil is 3 millimeter round regular, and both the direct and concentric refractive bis, and the lens is clear with the intraocular pressure is 14 millimeter mercury. This is the corneal diagram. Coming to the anterior segment examination of the left eye. The lid and lacrimal apparatus is normal, rhoplast is negative, conjunctiva is normal, sclera is normal, and cornea is normal in size. There is a paracentral thinning is noted with a conical protrusion of the central and the paracentral cornea, and a brownish deposit is seen more clearly with the cobalt blue filter at the base of the cone, suggestive of the Fleischer's ring, and fine vertical lines at the Descemet's membrane, suggestive of Voigt's striae is present. Prominent corneal nerves are noted, and normal with a normal endothelium and normal luster is maintained, and the corneal sensation is normal. There is a V-shaped downward protrusion of the lower lid on down gaze. That's Munson sign is positive and Rossetti sign is positive. And the anterior chamber examination of the left eye is normal in depth, optically quiet. That is normal in color and pattern. The pupil is 3 millimeter round and regular and reacting briskly for direct and concentric reflex. The lens appears clear with intraocular pressure. Intraocular pressure is about 12 millimeter mercury. This is slit lamp image showing a right eye and of the left eye. And coming to the fundus examination, the distant direct ophthalmoscopy, the media of the right eye, the media was clear and red glow is present. And with slit lamp microscopy using 78D lens, the disc appears, media is clear, disc appears normal in size and shape. The borders appears distinct and with a cup disc ratio of about 0.3 with a normal neuroretinal rim. Neuroretinal rim appears pink and healthy, and the vessels are rising normally and branching dichotomously with an arteriovenous ratio of about 2:3. And macula foveal reflex is present. And distant of the examination of fundus examination of the left eye shows a distant direct ophthalmoscopy, media was AZ, red glow is present. And with the slit lamp microscopic examination using 70D lens, the disc appears normal in size and shape. The borders is distinct with a cup disc ratio of about 0.3 with neuroretinal rim appears pink and healthy. And the vessels are rising normally and branching dichotomously with an arteriovenous ratio of about 2:3. And the macular foveal reflex is present. Summary: 22-year-old male presented with complaints of gradually progressive defective vision both eyes since 2018 and was referred from elsewhere to a hospital. And he underwent corneal transplantation surgery 5 years back, and he's on regular follow-up since then. And on examination, best corrected visual acuity is 6/7.5 and 6 in the right eye and 6/24 and 18 in the left eye. And retinoscopy showing dull glow in the left eye. And anterior segment examination, right eye shows a clear graft with a graft host junction is secure with intact sutures. And on left eye, Munson sign and Rossetti sign is positive, Fleischer's ring is positive, and Voigt's striae and prominent corneal nerves are present. The crucial diagnosis is keratoconus both eye, status post-penetrating keratoplasty, right eye. This is the topographic image of the patient of the right eye and of the left eye. Thank you.
Thank you, Dr. Nisha. You can come out from the screen. You can stop screen sharing. So, sir, Dr. Bhaskar Srinivasan, over to you. So you are muted. Please unmute.
When your history you're taking, I would also want to know the medications that the patient is on, especially that he's had a transplant, so he would already be on some medications for that. That did not come in your history.
Yes, sir.
Second, when you're doing refraction, what do you see when you do a refraction in a keratoconic patient?
Normally, the Scissoring reflex should be present, sir, but I couldn't appreciate the Scissoring reflex in the left eye. The dull was low and Scissoring reflex could not be I couldn't appreciate.
So you have to, whatever is positive or negative, the examiner would want you to specifically mention, because we would expect you to speak of scissoring reflex when you're doing a refraction. Similarly, when you're looking at the fundus, whether with a direct ophthalmoscope or an indirect ophthalmoscope, there is a particular sign which is supposed to be
All
there,
droplets, sir.
especially if it's an advanced oil droplet. What is it called? Name of the sign?
Charlot's sign.
So,
Charlot's.
yeah, so you have a set of signs in keratoconus in your, and instead of putting your signs at the end in that initial slit lamp examination itself, I would have advised you to write, okay, Munson sign is positive, Rizzuti sign is positive, because once you are telling that, the examiner will then start asking you, okay, what is Munson sign? What is Rizzuti sign? So you're kind of trying to take the examiner, guiding the examiner to questions that he wants, that you want him to ask. If you leave it till the end, he will suddenly get irritated and say, okay, you have not mentioned this sign, you have not mentioned that sign. So whatever is your slit lamp signs, which are present or not present, let it be in your initial slit lamp examination itself. Specifically mention about scarring. If it is there, anterior Bowman scarring or a deeper scarring if there is a eye drops. Here there was no eye drops, so we are not so worried about it. In terms of grading of keratoconus, how would you grade keratoconus?
It is classified into mild, moderate, severe, and advanced. And in mild, it is the keratometric reading is less than 48. Moderate is 48 to 52. Severe is more than 52, and advanced is more than 62. And according to Amsler-Krumish classification, it is classified based on the myopia and astigmatism. It is classified into 4 grades. The myopia and astigmatism, if it is less than 5 diopter, 5 to 8 diopter, 8 to 10 diopter, and the refraction not possible. And based on in grade 1, Vaux striae is present. In grade 2, the pachymetry reading will be more than or equal to 400, and in 3, it is 200 to 400, and in grade 4, it is less than 200. And the corneal radius will be more than or equal to 48 in grade 1, stage 1, and it is more than 53 in grade 2, more than 53, and 53 less than 53, more than 53, and more than 55 in grade 4. And
So
based on the shape of
yes, yeah,
based on the shape of the cone, it is classified into nipple, globus, and oval cone. Nipple is less than 5 millimeter. The size of the cone is less than 5 millimeter, 5 to 6, and more than 6.
And then you can also say with systemic association, or with ocular association, or without ocular association. So when you're writing in terms of your theory, you need to be, if there are 4 classifications, you need to know all the 4 ways of writing it. From a practical point of view, it doesn't make a huge difference. Neither does it make a difference when we are actually clinically managing these patients. But when you're writing your theory, okay, you need to know you're classifying it based on mild, moderate, severe. You're classifying it based on Krumwich classification. You're classifying it based on the Bellin's ABCD classification. You're classifying it based on the type of cone, and you're classifying it based on whether it is associated with any ocular or systemic associations. So coming to what are the ocular associations that you would see with keratoconus?
Ocular association mainly due to atopic keratoconjunctivitis, retinitis pigmentosa, Leber's ocular digit amaurosis, and aniridia post, and retinitis pigmentosa, and the
Okay, remember 4 things, it's sufficient. You don't need everything.
systemic association is Marfan syndrome.
Associations.
Systemic association, Marfan syndrome, osteogenesis
Yes.
imperfecta, and Down syndrome, and floppy iris syndrome.
Right. So you basically need to
Ehlers-Danlos.
know Ehlers-Danlos. So you need to know what are the systemic associations. You need to know what are the ocular associations. Now your patient, the right eye what, just go to the pentacam image that you showed. Yeah, just left eye. Read me the maps. What does the pentacam image show you?
Okay, this is a keratometry reading of patient named Sadzi of left eye with showing quad map with axial sagittal thickness map, anti-elevation, post-elevation map with Q, the quality signal as okay, and with Q value of about minus 0.2.79 anterior and 0.3 minus 3.24 posterior, and the central K reading is 67 anteriorly, and there is a superior inferior difference of more than 7 diopters, and in thickness map, the central thinnest local is 322 micrometer, and on anterior sagittal map, it is more than, it is above the normal range based on the best fit sphere. It is above the normal range, and then it is more than 15. Difference is more than 15, and in posterior also it is above the normal range.
So what you would basically say is name of patient, date of investigation, eye. Because date of investigation is also important, especially because you're going to be looking at follow-ups of these patient. Then you're looking at it's a 4-quad map, which gives you the sagittal curvature, thickness, elevation front, and elevation back. Your sagittal curvature, then you speak about the shape. It's basically still more or less a central cone, because you have a diffuse central steepening, which is fairly steep with almost like advanced keratoconus, which is 67 or an average, or you can mention the K max as far as your anterior curvature is concerned. You can then go on to say that the pachymetric value is very low, and you have high anterior and posterior elevation values. Based on the topographic appearance, this map might be of a patient with advanced keratoconus. You will say might be, because sometimes just some kind of scar or some kind of trauma can also give rise to a bit of a thinning. It's not keratoconus by definition is a non-inflammatory, non-scarred kind of a condition. It scars when it reaches the end stage. So you would always compare your maps, compare the clinical findings, and then make a diagnosis of keratoconus as such. So this would be the way that you would read the map. And now this patient has had a keratoconus surgery done. I mean, he's had a DALC or a PK done in the other eye. How would you differentiate?
Usually there's a surgical peripheral iridectomy as present. Usually it is done in penetrating keratoplasty.
That gives you a clue, but it could have been done, if it was inferior, it could have been done for a DM detachment, and they've had a full fill also. But your PI was superior. So most likely it is a full thickness graft. Apart from that, you're going to look at your slit to see if there is any interfalc. You will not be able to see subtle folds in the deeper layer, which will tell you it is, which will tell you that it could be a DALC. Your OCT, if whatever clinically you're not able to see, your OCT might give you certain clues in terms of if it is less than 100 microns, 70 microns, you might not be clinically able to appreciate it. The OCT will pick up the changes as such. Now this second eye, the left eye, what would you offer the patient? Vision with glasses is pretty poor. He has only 624 vision with glasses. What would you offer the patient?
Either contact lenses or collagen cross-linking.
Okay. So you want to offer contact lenses, or you want to offer collagen cross-linkage, or cross-linkage followed by contact lenses?
Cross-linking followed by, he has used contact lens for 5 years back and he was not tolerating, so I will prefer collagen cross-linking with the right.
Okay, what is the thinnest pachy that you're seeing in this map?
Sorry, sir.
What is the thinnest pachy that you're seeing in the map?
307.
So 307, it's 332, I think. Yeah, thinnest pachy.
Huh.
So
322. It is 322, sir.
330 Paki, huh?
320.
322. 320 Paki, don't you think is a bit low for us to safely do cross linkage?
With hypotonic
In a
C3.
hypotonic, yes, but there are two issues here. One is you will have to first do a contact lens trial, because if the contact lens he is not going to wear, or the contact lens fit is not good, then there is no point in doing a cross linkage, because anyway you are not going to visually rehabilitate the patient with any active form. Second, when you're dealing with such thin corneas, I would actually want to get an OCT to check the epithelial thickness also. Sometimes if there's a very faint scar that is missed, you might have, instead of having a thinning of the epithelium at the apex, you might also have occasionally a thickening of the epithelium at the apex. Because when you peel off the epithelium, and that residual stroma has to be sufficient so that your endothelium is protected. Third, what are the ways of doing cross linkage for a thin cornea? You said
I will.
hypotonic one. Then
What are the sorry, sir. What
what are the ways that you can do cross linkage in thin corneas? You said hypotonic is riboflavin, that is one. What are the other options? You've heard of some kind of contact lens assisted cross linkage?
Yes, sir.
Okay, so basically, when you use the normal riboflavin, it has dextran. So that kind of dehydrates the cornea. So you want
0.9% sodium
that
chloride.
doesn't have dextran to hydrate it. A hypotonic CXL, hypotonic riboflavin will increase it somewhere close to around 70 to 80 microns. Other way of doing it would be to use some kind of, which the Agrawal group speaks a lot about, is contact lens assisted cross linkage. But that contact lens has to allow your ultraviolet light to penetrate through the contact lens, so that you'll be able to see in the bottle whether it filters the ultraviolet light or it allows the ultraviolet light to go. That would be the second way. The third way would be, you could look at an epithelium on cross linkage, but then the effect of epithelium on is not as good, because the penetration of riboflavin is reduced, and the epithelium itself blocks the ultraviolet light. So your depth of cross linkage gets and the intensity of cross linkage gets affected. Fourth is Hafezi's protocol of reducing the duration of riboflavin and reducing the intensity or timing of riboflavin that you can apply, so that you are safe. But the most important thing here would be to check the contact lens fitting and be sure that the patient is ready to wear contact lenses. If he is not ready to wear contact lenses, you might actually consider going in and offering him a DALC, because that becomes a better bet. What else can you offer this patient if you don't want to do a cross linkage? You don't want to do, not as bad as this, but slightly less worse condition. What are the other ways of rehabilitating a keratoconic patient who is not having very great vision with glasses, but wants to have less dependence on contact lenses?
Intacs.
Yes, so you have the
Intracorneal.
tax, and you have the option of now what is called as KSOS, which can help in regularizing the cornea to a certain extent as such. So this patient with a 330, 322, what kind of lens do you think would fit him? A rose K would fit, or a RGP would fit, or a scleral lens would be better? What do you think is better? So when you have such an advanced cornea, you would probably prefer a scleral lens rather than something which sits on the cornea, because the lens doesn't remain as stable. You will still do a fitting of the rose K or the advanced rose K, because that might, if you're able to get a fit with that, the cost significantly comes down. The advantage of the scleral lens is, since it's not sitting on the cornea, even if the condition increases, because of the fluid which kind of compensates for the gap, you don't really have a change in the fitting of the contact lens and a change in the refractive error of the contact lens, even if the condition progresses as such. The right eye, what other investigations you could have done? He's had a graft. So what is the investigation? And it's about 4 years. What is the investigation that you would have wanted to do?
In a post keratoplastic.
Yes.
Look for Other than corneal topography,
Specular counts, to know what your counts are. You have a transplant which is 5 years down the line. You would want to have a topography because you can then decide whether you want to remove the sutures based on the astigmatism. Is astigmatism, you might keep the sutures in place, you don't have to remove it. But I would also want to get a specular done because it's 4 years since the transplant and we have not had any documentation of the endothelial health. A pachymetry and a specular would give you an idea about the endothelial health status as such. As far as the left eye is concerned, if you have to do a transplant,
sorry, sir.
what is the choice of transplant for the left eye?
A deep anterior lamellar keratoplasty.
How would you do? Which technique would you want to do?
And big bubble.
Yeah, so be confident. You either have a big bubble or you
Canvas
have
big bubble.
a manual dissection. You have variations of it. You can have a groove and peel, but primarily the two main things would be a big bubble that allows you to create. So what are the types of big bubble that are there?
Only over the Duas layer and below the Duas layer.
So what is type 1? What is type 2? What is type 3?
And type 1, the air bubble is injected above the Duas.
Okay.
And in type 2, it is below the Duas
Below
layer.
the Duas layer. And type 3 is a combination. Is a combination. You have air bubble in the between the duas and the posterior stroma and between the duas and the desmids. Which is the most I mean, between type 1 and type 2 or type 3 bubbles, which is easier in terms of surgically deflating, or which bubble you are more worried about when you operate?
Type 2.
Yeah. Why?
It is beneath the Duas layer endothelial.
Duas is supposedly a slightly more stiffer tissue. So the risk of perforation is much higher if you get a type 2 bubble as compared to a type 1 bubble as such. Yeah, now you can ask. I've been asking quite a bit.
Sir, I think you've covered everything now. So, Nisha, just for the postgraduates, can you just go back to your history part? And if you could just illustrate why you asked those specific questions and just tell the significance of asking those questions so that they don't miss it out when they get a case of keratoconus. Could you share your history, please?
Yes, ma'am.
The other thing would be, yeah.
There's a history of frequent change of glasses to look for the refractive errors, and there was no complaints of pain, redness, photophobia, glare, and there was no history of corneal hydrops or heredity of irregular astigmatism, and there was
So
no
just to
history
be
of.
clear, in your particular case, is a young boy with painless drop in vision in both eyes, progressive, correct? So what would be your DDs at this point of history itself?
Considering his age, the patient with gradual onset defective vision, the first one will be refractive errors and the corneal degenerations, corneal dystrophies, then keratoconus and a developmental cataract and a juvenile glaucoma or retinitis pigmentosa or any macular pathology, macular degenerative diseases, hereditary macular degenerative diseases.
Okay.
And
so now that you also have a history of corneal transplantation in one eye, like what all does it rule out for you? among the ones that you listed?
Among those, it's not a corneal refractive this
Do the retinal pathology still fit in?
retinal pathologies can be ruled out. Macular degeneration and retinitis pigmentosa and glaucoma and cataract can be ruled out. And the other one is corneal.
Glaucoma and cataract, not necessarily, but retinal pathologies are ruled out. So you're left with refractive error, keratoconus, glaucoma, and could have a coexisting cataract. So now with the corneal transplantation history coming in, it narrows it down more to keratoconus.
Keratoconus.
Yeah. So now that you have an idea that it is keratoconus, what are the leading questions that you'll ask the patient?
Is there any history of frequent eye rubbing, or is there any history of atopy or allergy? And if there is any frequent change of glasses, and whether there is any history of pain redness, suggestive corneal pain redness, photophobia, or suggestive corneal eye drops.
Sudden drop in vision, which would
Sudden drop in vision with
have been the
redness.
cause for the transplantation. Yeah. Can you go on to your next slide? Yeah, next. So in family history, sir has already illustrated in the systemic part. Next slide. We have already covered the systemic associations. Coming to your ocular examination, you have written no signs of orbital fat atrophy. I don't think you can write that. You can just write that ocular position and everything is normal. But why is that so important? Just for everybody to know.
As a result of chronic eye rubbing, there is a chance of orbital fat atrophy in case of any atopy in patients with atopy, or in Down syndrome patients, or Leber's congenital amaurosis. And there will be signs of fat atrophy, fat loss will be there, and signs of atrophy will be there.
Yeah, since they keep rubbing their eyes, so an examiner can ask you, what were you looking for when you were looking at the ocular posture and everything? What were you looking for? Okay, next slide. Next.
Once you can just go back. Go back. Yes. No, so again, when you're talking about Fleischer's ring, the examiner can tell you what are the other causes of iron lines in the cornea that you would see. So you will need to know what are the different iron lines that you can see in the cornea. What is Hudson-Starley's? What is Ferry's line? What is what is pseudo-Fleischer's ring, by the way? You have Fleischer's ring. What is pseudo-Fleischer's ring? So when you have a hyperopic correction, because the periphery is thinned out, so the central bulges, so you have a tear instability in that area, and that is what causes a pigmentation around the base. So that is called a pseudo-Fleischer's ring. Why do you get a Fleischer's ring?
That is due to the tear film pooling abnormality, and the basal epithelial cells, the hemosiderin will get deposited in the basal epithelial cells, and this will appear as brown deposits in cobalt fluid.
Name 5 other iron lines in the cornea?
Case of Fleischer ring.
Okay.
Stocker's line.
Okay, where do you see Stocker's line?
Interregion.
Okay, then. Hudson-Starley. Where do you see? So when you're any of these things which have associated names. So for Fleischer's ring, if you want the examiner to ask you a little bit, you can mention Fleischer's ring and pause a little bit. The examiner might actually ask you. So when you are answering a case presentation, if you can lead the examiner to things that you want him to answer, in your mind you are clear, the answer will come out fast. So you will have, there is I think in one of the books, there's a very nice pictorial representation of all the, I think in Krashmar, all the different types of iron lines. There are about 7 iron lines that you would need to know, at least more in terms of the theory part if you get a question, and in the practicals, at least to know a couple if the examiner asks you. Next. Yeah, and again, I mean, this you've taken from the thing, but in your exam, maybe you would want to do a color coding if in your DNB examination. So you will need to know what is the color for documenting each of the corneal findings. Just like the retina, people have a color coded way of documenting. There is a color code even for cornea, even though we don't use it. It's nice to do it, so the examiner feels that you are putting that much extra effort in your findings. And next. So basically the only other thing would be with respect to contact lens fittings, how you would do a contact lens fit if the examiner asks, but that's generally only if you've really answered well and he wants to pull your leg. Otherwise, they don't go into is concerned. The other thing would be in terms of steps of PK or steps of DALC that they could ask you, at least what all is done in terms of the steps you would need to remember. What are the other ways of visually rehabilitating these patients? Can something else also be done for some of these patients who have very high refractive error also and have keratoconus and their glass vision is reasonably good? Do you have anything else to offer them and they want correction? For a very small subset of patients whose glass vision is good and they want to be less dependent on glasses, primarily the keratoconus with a high myopia, where your glass vision matches your astigmatism to a reasonable and glass vision is good, you have the option of implantable collamer lens or some form of phakic intraocular lens to correct of vision will still be best with contact lenses. So it's not that it is going to improve their quality of vision as compared to contact lenses. It's only going to make them slightly less dependent on their glasses. And this is only for patients where the glass vision is reasonably good and they have a high myopic refractive error, which you're correct with the ICL, because they are not going to be candidates for any form of laser refractive procedure as such. So from your theory point of view, you will need to have an algorithm in terms of how you would manage a keratoconus patient vision with, or is it a you cannot mention about progression in the first visit. So unless the Paki is very, very thin, like in this case, if it say 370 or 380, I would have said, okay, I would want to do a cross linkage for this patient. With the 320, I would generally not go ahead with a cross linkage. So if it is 370 or 380, I would have done a cross linkage at the first visit because I cannot wait longer for it to progress. If it was 420 or 430, I would have waited 6 months, check for progression. If progresses, offer cross linkage. So that would be one. Then you would be looking at vision. How's the vision with glasses? How's the vision with contact lenses? If vision with contact lenses is good and he's ready to wear contact lenses, great. If vision with contact lenses is not is good, but the patient doesn't want to wear contact lenses, then when you're doing cross linkage, you have to decide whether you want to combine something along with cross linkage or following cross linkage to improve the corneal shape so that their glass vision improves, or for a very small subset of early keratoconus where people do a topography guided laser ablation along with cross linkage to regularize the cornea so that their glass vision improves. So once their glass vision is improved and they are stable, great. They are unstable at that point of time, then you will have to consider continuing with scleral lenses till the time they are comfortable, and then consider a DALC or a PK at that point of time. If they are stable but they have a very large refractive error and they want to be less dependent on glasses, then you would look at whether you would want to do a ICL. If they are 55 or 60 years of age, old keratoconus, wearing contact lens, wearing glasses with cylinder, and you have to plan for a cataract surgery, Then again, you might want to decide based on the topography, the topographic astigmatism, the acceptance astigmatism, and you can then take a decision whether you would want to do a toric lens or you would want to do a plain cataract surgery with a monofocal lens as such. So you're looking at stability, you're looking at vision. So your thought process when you approach these patients have to be very, very clear, because both these arms have to be there in your treatment algorithm.
Nisha, could you
Some
just
of these
highlight
points
the
might be
points?
high for a PG, but you need to know.
Nisha, could you just highlight the points that you would read in a topography? What are the main points that you would read in each
In a
map?
topography,
Yeah.
in a topography, you should know the first of all, we should look at the age of the patient.
So
A
what does
patient
this
detail,
QS mean? What does this QS mean?
a quality signal.
Yeah. So first you have to look at the quality of the scan. Okay. And what does this Q value tell us? That it is more negative. What does it mean?
It indicates asphericity of the cornea. Normally, it is 0 to -1. If it is more than 1, it indicates the cornea is asphericity is there. Prolate
It's more of a prolate cornea.
cornea.
So now coming to the axial curvature map, what are some? Can you tell me the 3 points that you would look for in an axial curvature map? What are the things that you will be telling?
Central corneal diameter, keratometry, keratometry values, inferior superior difference, and
How much is it usually, or what would you call abnormal?
if it is more than 1.4 diopter, it is considered as according to Rabinowitz criteria, it is considered as abnormal. And the skewing of the we should also look for the skewing of the radial axis. If it is more than 21, it is considered as abnormal. And the keratometric reading of the central cornea should be compared with the fellow eye. And if it is more than 1 diopter, it should also be considered.
What is the other thing that you'll tell? What Sir also illustrated. You should also tell about the shape. You would see an asymmetric bow tie or an asymmetric bow tie with an inferior steepening. In this, there is not a clear shape, but usually you should tell about the shape, the inferior superior difference, and the skewing of the radial axis. And just can you just repeat what are the normal values that beyond which you would call it a keratoconus in anterior elevation and posterior elevation maps?
In anterior elevation map, if it is more than 15, and in posterior elevation map, if it is more than 20, it is considered as abnormal. And
okay, and in a corneal thickness map, what are the parameters that you will look for? What are the things that you will be telling?
the corneal thickness map, the thinnest local is looked for.
There is something there's something like X and Y written there next to the
X and Y axis.
what is the significance?
If the Y coordinate is more than 0.5, more than less than 0.5 is normal.
Yeah. So what does more than that 0.5 indicate?
The location of the thinnest from the
so it is shifted more inferiorly. Yeah. So,
yeah, but then if you say 0.5 is normal, this is only 0.45. Do you think this is normal?
Less than 0.5 is no.
That is a criteria that we use for normal patients when we do a refractive surgery to screen out keratoconus. When you have such an advanced disease, and if you say a 0.5 normal, I would ask you whether this is 0.45. Is this normal? So this is called as
digging your grave.
Digging your own grave.
So yeah, that would be the order of reading it. You haven't put the bad.
Also, yeah. You also said that you need to check the other eye. What is the property of both eyes being almost similar in topography is called? The topographic images of both eyes are almost mirror images. What is that called? It's called a term. Enantiomorphism. Enantiomorphism.
Enantiomorphism.
I think Sir has set you in the right path to get a gold medal. So it's covered everything.
Most of it is done. You will primarily get caught in refraction and your clinical findings. So they will generally harp more on all the signs. So you need to know how to elicit the signs. They will ask you how to elicit a Munson sign, how to elicit a Rizzuti sign, what is Charlotte's sign. So those would be things that they might ask you to elicit in the patient. Topography maps they might ask you to do. Again, when you talk of values of elevation, they are primarily for pentacam of elevation. And so if you're looking at a slightly different topographic map like a CSO map, they don't decide on values. It's based on certain other, because there the BFS, it's not a best fit sphere, it's a best fit toric ellipsoid. So they here in pentacam we take a value of more than 15 more than 16 micron elevation in the posterior elevation is supposed to be suspect, and more than 12 in the anterior elevation is supposed to be suspect. Whereas for the other some is terms like the Galilee or the Cirrus, they don't talk about the particular value of the elevation. They only talk more about the asymmetry between the superior and the inferior, both of the anterior curvature, the thickness, and the posterior curvature, rather than talking about specific elevation points. So if you have pentacam, then they might even go on to what is Bellin-Ambrosio display, and how is it read. So what is Bellin-Ambrosio display? So
Based on
the steepest portion of your cornea, the curvature in that area is eliminated, and the 4 mm, and then you draw a best fit sphere excluding the steepest area. So your curvature changes, and when that changes, the steepest point tends to kind of become more prominent. So it tends to kind of get highlighted, and then you have values which say that if this difference is less than 10, less than 12, or it is more than 15, then it is abnormal. If it is less than 10, it is normal. Between 12 to 15, it is borderline. So those come in the good part of most of these machines is you really don't need to remember the values, because the values are color coded in terms of traffic signal kind of a thing, where you know this is normal or this is borderline or it is abnormal as such. So that again, if you have a topography as a question in your spotter or something, they might ask you about what is Bellin-Ambrosio display. That should be more than sufficient for keratoconus case. And if the patient has allergies, it will go on to VKC.
And if the examiner is watching you examine a keratoconus patient, avert the upper lid to look for papillae. It makes a difference.
So even in your specific examination, mention no papillae. You can say no perilimbal pigmentation, because these are all signs suggestive of VKC. So the examiner knows that you have specifically looked for it.
Okay, Nisha, can you stop the screen sharing?
Yes.
Okay, thank you, Dr. Nisha. That was an excellent presentation, and it was like a real exam, I think, a real PG exam. I think you are not scared. You are not scared by the questions, I think. And on behalf of the scientific committee, I express my sincere thanks to Dr. Bhaskar Srinivasan and Dr. Sugaranjini for leading the questions. And I think it was 10 minutes presentation and some 50 minutes discussion, right? And all the aspects of the keratoconus is covered, well, from the history till the investigations and treatment, everything. I think those who are watching the program, I think it will be a great help for you to the examination if such case comes. And we had a couple of questions, and I think all were covered in the discussions, so I don't have to repeat those questions again. So anything to add, Dr. Sugaranjini, or anybody who is in the Zoom?
Good presentation, Nisha.
Yeah.
Thank you.
The presentation was good. You were answering confidently, but it's always nice to kind of lead the examiner. So any case, think of the questions that you want the examiner to ask. Pause during those phases. So before you start your case presentation, you know these are the questions that can be asked, and you can give a little bit of a pause, and the examiner will ask you a question in that phase.
Okay.
Okay. So shall we conclude? Anything? Any questions again, Nisha?
No, sir.
Okay. So once again, thank you, Dr. Bhaskar Srinivasan and Dr. Subiranjani. Yeah. So
Thank you, sir.
thank you,
Thank you.
and have a good night.
Thank
so,
you, ma'am. Thank you, sir.
So after the 2 weeks, we'll be having again such sessions. Again, will be mostly it will be on Monday. So we'll